Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about prostate cancer with Dr. Michael Leapman. Dr. Leapman is an associate professor of urology at the Yale School of Medicine. Here's Dr. Weiner.
I just want to start off a little bit asking you how you came to be interested in prostate cancer and, what led you down this path.
Yeah, I've been fascinated with prostate cancer. I was drawn to the field of urology, in medical school, rotating through surgery. And when I came upon urology, I was really fascinated by a field that was focused on treating patients with cancer, but also tasked with the role of preserving or whenever we can enhancing quality of life. And so that challenge of dealing with cancer and controlling it while also helping to walk that razor's edge of quality of life is what got me interested in prostate cancer. It's also an area where there's really intense decision-making conflict. These are tough decisions to make. And so I sort of revel in that opportunity to help connect with patients and help them navigate that experience.
Sure. Before we drill down into prostate cancer, maybe you could just tell us a little bit about the various cancers that comprise urologic cancers. A urologist, who is the surgeon for the people who have these cancers, it takes care of a number of different kinds of cancer.
Yes, urologists are doctors who take care of the genitourinary tract. So in general, if something makes urine or close to it, it really falls into our umbrella. Okay, so we're the plumbers. That's kind of the way I think about it. And so that encompasses the kidneys, the ureter, which is the tube that drains the kidney, the bladder, the prostate in men, the penis and testicles in men. Urology is a small field, but it's a diverse field. And so urologists also deal with issues of urinary incontinence, female pelvic medicine, and urogynecology as well. There are also pediatric urologists. So in the cancer world, we focus on kidney cancer, bladder and urothelial cancer, prostate cancer, testis cancer, penile cancer.
And of course, the most common of those, not that the others are so very rare, or some of the others are so very rare, but the most common is indeed prostate cancer.
Yes, it is.
And how big a problem is prostate cancer? We'll just talk about the United States to begin with.
So prostate cancer is consistently the most commonly diagnosed solid cancer in men, with an estimated 300,000 cases diagnosed this year. And so it really is very, very common, and is probably more common than we even diagnose it. And so it really is the number one. But the real question is, what type of cancer is it? And is it something we need to treat in all people? But it is a major public health challenge in the United States, and doesn't appear to be going anywhere, with some modeling studies suggesting that we were going to probably see more cases with time.
Well, and it is a disease that becomes more and more common as a man gets older.
Yes.
So my understanding is that in autopsy studies of older men, that a very, very high proportion of individuals have at least some focus of prostate cancer.
That's exactly right. So I mention this to a lot of my patients when we have these discussions, that just how common it is in people if you go looking for it. So exactly right. When they've done studies of people who pass away for another reason and they look in their prostates, up 50% of men in their 80s will have some evidence of cells that look like prostate cancer. And these are folks who passed away from another reason. So it tells us it's extremely common if we go looking for it.
So I guess the other relevant statistic would be how many people die from prostate cancer every year?
Right. So, it's about 30 to 35,000 people who die from prostate cancer. So even though it's very common, that's still a very large number. It's the second leading cause of cancer death in men after lung cancer.
But nonetheless, relatively small proportion of men who are diagnosed with prostate cancer ultimately lose their lives to it. So certainly well under half.
Exactly right. That's exactly right. Most men have an excellent outcome if they're diagnosed with prostate cancer and do very well with treatment.
All right. Well, maybe you could tell us a little bit about some of the advances in prostate cancer over the years, and we'll get to screening. We'll get to some of the decisions around early diagnosis, but maybe first just some of the headlines in terms of advances.
A lot has changed. I was on this show maybe 5 or 6 years ago, and I remember being asked that question. And when I come back today, a lot has changed in 5 or 6 years. And so I think both in terms of how we treat localized disease. So when patients come and they have a cancer that we think is only located in their prostate, we are changing our approach. The backbones are still radiation and surgery, but we have a whole flourishing field called focal therapy or ablation, where we use energy, different forms of energy, to destroy parts of the tissue or the entire prostate without removing it or radiating it. We have a large program of ablation at Yale where we offer these treatments, various forms of treatment that aim to improve quality of life or preserve quality of life while also controlling the cancer. We've also made improvements in how surgical prostatectomy is done with robotics. The robotics platforms are continuously getting better with single port prostatectomy and ways of approaching and removing the prostate that are less invasive.
So single port prostatectomy means you're essentially inserting some sort of device into one area?
Yeah, well, it's a robotic device. So robotic prostatectomy has been a big change in the field over the past 10 or 15 years. But the typical robotic platform involved putting 5 cameras in a laparoscopic configuration, so 5 little keyholes in the belly. There is a surgical device that actually uses one incision, and then all the instruments fan out from one incision.
And so, how big is that incision?
The incision is about 5 centimeters, so it's a little bigger than one of the small incisions, but it is in one area. So it allows us, in general, to get into smaller spaces. And so it's used in the prostate, but it's used also in other applications as well.
And then you somehow control what's going on through the robot.
Exactly. So the robot, and that's in general in robotic surgery. Now we are hearing a lot about robots and AI and autonomous devices, autonomous cars. That is not happening yet in surgery. I mean, it may be coming down the pipe, and I think it's very likely that there will be truly autonomous surgery or robot assisted surgery. But right now, there's nothing like that. So when someone has a robotic surgery, we are still driving the instruments, but it allows us to get into a small space without making a big opening. Fundamentally, that's what it's doing. It's allowing us to get into a small space and also moving in ways that the human hands can't really rotate 360 degrees and get in tight spaces.
So it gives you more dexterity.
That's right. That's right.
But if I were coming to you with prostate cancer, I don't have to worry that the OR is going to be empty and there's just going to be a robotic device and some computer telling it what to do.
No, absolutely not. No, it's still we're still doing this, but that may change. I mean, at some point, if you look at there are AI platforms that can drive a car from your house to the hospital. There's a lot of complex information that those systems are navigating, but there's nothing like that going on right now. It's all done by a very large human team still.
Yeah. Oftentimes men are making a choice between surgery and radiation. What does that choice look like?
Yeah, I mean, we're fortunate to have multiple very effective treatments for prostate cancer. And so surgical removal of the prostate is one, but one that is also very effective is radiation to the prostate. Radiation can be given by itself or sometimes with a course of hormone medication to decrease testosterone levels. And so the decision about where to go is often a complicated one. The surgery is more invasive because it is a surgical intervention. The radiation offers the advantage that no one touches you. There's no hospitalization. And so the pros and cons really relate to undergoing a surgery if people want to. But both deliver a very good outcome and both have a good chance of controlling localized prostate cancer.
And is one at all better than the other?
We don't think so. There's never been a head-to-head study that has compared radiation to surgery for the type of cancers that we treat nowadays. But from the retrospective studies, people who've been treated in the past, they seem to come out more or less the same. There are some relative advantages to one and disadvantages to others. When we do surgery, we remove the entire prostate and we can get a sense of what is truly in there rather than just getting a biopsy of it. And we can selectively add more treatment in the future if necessary. Radiation has the advantage of having less of an impact on urinary continence, which may be a higher risk with surgery. But there are also potential drawbacks with each of them. So that's why I think the main thing is having that relationship with your doctor, being in a setting where you can help make a decision that is tailored to your individual interests. A lot of folks have a strong sense of where they would like to go. And so I think that's where we see ourselves as really facilitating that decision.
And before we take a break, maybe we can just spend a couple of minutes talking about some of the other unintended consequences of either prostate surgery or prostate radiation, the kinds of side effects that I think many men are very concerned about. So there's incontinence. There's also sexual dysfunction.
That's right. Those are the big two. Because the prostate sits attached to the bladder. You know, when a person urinates, their urine passes from their bladder through their prostate. So anything we do to that sensitive area runs the risk of affecting urinary control and sexual function. The nerves for erection course right underneath the prostate. So it's in a sensitive spot. Those are risks. Even with expert surgery or expert radiation, there is a risk that urinary health could be worse. And after surgery, it can lead to urinary leakage. So when you laugh, cough, or sneeze, people can dribble urine for a period of time, or in some cases permanently. And erections can be more difficult.
And is that something that gets better over time too? Or?
It does. After surgery, most people improve, but in some cases it can be permanent or can require assistance where someone didn't need it before. So medications like Viagra or Cialis are often needed for some people, at least for a period of time.
And presumably these are all the conversations you have with patients when you're counseling them about these various options.
Right. Well, it's really that balance between cancer control and functional status. And in many cases, we do bring patients safely back to where they were before. That's really our objective in any of these, is to think about balancing cancer control with preserving quality of life.
Well, I think we're going to take a break for just a minute. When we come back, we're going to focus on really 3 topics. Talk a little bit about screening. We'll talk about the approach that increasingly is being taken where someone is diagnosed with prostate cancer and they may not initially undergo treatment. They may be observed. And finally, I want to touch on the whole subject of prostate cancer in younger men, which is by no means the most common age when you see prostate cancer, but it still happens. So when we come back, I'll continue this conversation with our guest, Dr. Michael Leapman.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where their liver cancer program provides continued care following treatment to manage underlying liver disease and monitor for possible recurrence of cancer. More at smilowcancerhospital.org. Breast cancer is one of the most common cancers in women. In Connecticut alone, approximately 3,500 women will be diagnosed with breast cancer this year. But there is hope thanks to earlier detection, non-invasive treatments, and the development of novel therapies to fight breast cancer. Women should schedule a baseline mammogram beginning at age 40 or earlier if they have risk factors associated with the disease. With screening, early detection, and a healthy lifestyle, breast cancer can be defeated. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital, to make innovative new treatments available to patients. Digital breast tomosynthesis, or 3D mammography, is also transforming breast cancer screening by significantly reducing unnecessary procedures while picking up more cancers. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Good evening again. This is Eric Weiner with Yale Cancer Answers, and I'm speaking to our guest, Dr. Michael Leapman. associate professor of urology at Yale University. So I want to move on and talk a little bit about prostate screening. Of course, cancer screening, generally speaking, is very important. We ideally want to diagnose patients most of the time with the earliest possible cancer. Screening is available in a number of areas, and I think that perhaps in the area of prostate cancer, there's both more data than in some other areas. There's also perhaps every bit as much controversy as there is in any area. So, Michael, thoughts about prostate cancer screening? When did it all start?
Yeah, absolutely. It's an enduring topic that really hasn't been settled. But I think this really goes back about 30 years to the early 1990s with the isolation and advent of PSA. And PSA is a blood test. It's a protein that is made by prostate cells. So cancerous cells and non-cancerous cells of the prostate make this protein. And stands for prostate-specific antigen. And so scientists as early as the 70s were able to identify this in the blood and really began to become a biomarker or a test that we would order beginning in the early 1990s. And it was found that was a pretty good marker for prostate cancer. So,
and if I can just interrupt you for a second, that's also the same test that's used at times when we're taking care of patients who have advanced prostate cancer, or for that matter, screening them for recurrence. And it is used in those situations as well in people who have been already treated for prostate cancer.
That's exactly right. It's the same test. PSA has been on the scene for over 30 years. It is an amazing test if you really think about it. And it has transformed how we diagnose prostate cancer, how we treat prostate cancer. And it has really shifted the lives and trajectory of the disease for probably millions and millions of people. The issue is that PSA levels can be elevated in people who don't have prostate cancer. And in some cases, they're not elevated in people who do. But overall, it's a pretty good test. And, it was really, so that question of screening came up in the 1990s when it was really performed, en masse. Essentially, people were going to their doctors, getting PSA screened. And if the numbers were elevated, being monitored or being evaluated further. So screening really has been that PSA blood test. And the question has been, well, we know PSA is very good at finding these early stage prostate cancers, but will it lead to people living longer? Will it reduce their risk of dying from prostate cancer? That has been the fundamental question that people have been wrestling with and has been evaluated in a number of clinical trials over the years.
And if I can ask you, the people who have prostate cancer and don't have an elevated PSA, how common is that? And are those cancers any different?
It seems to be the minority. So it's not very common that we see it. Most people, it is elevated. In some cases, after treatment, after many rounds of treatment, PSA stops being produced by prostate cancer cells. And so at some point when the cells are not responsive to androgens or testosterone, you may see growth of prostate cancer without a rise in PSA. But overall, it remains preserved even after people have been treated for prostate cancer. So it's a useful marker for people who have been treated to know where they stand.
What are the reasons that a PSA goes up if you don't have prostate cancer?
So inflammation, infection, growth of the prostate can all cause PSA to go up. And some people just genetically are predisposed to have higher PSAs than others. So there's some interesting research showing that you can begin adjusting for that genetic variation.
But let's say someone's having screening, and if the level is particularly high, it's more likely to be a cancer than one of these other benign causes.
That's true. And so I think that's really where there's been a big revolution in how we approach this. So, 10, 15 years ago, if someone had a high PSA level, they would come in and get a biopsy, essentially a procedure where we would take little pieces of the prostate and see if there was cancer there. Our approach has shifted. So if a gentleman comes to see me and his PSA is elevated, we will do imaging to confirm whether or not there's something there. And that has allowed us to avoid doing a biopsy to rule out significant cancer in a number of people, which is great. If we can do something non-invasively, that's a big win. In some cases, in most cases, it will help identify where a tumor is located so we can take a more accurate biopsy of it.
So when I'm asked the question by a friend or an acquaintance, they'll say, well, you work at Yale Cancer Center. Tell me, should I have prostate screening? And when should I start it? And how often should it be done? What do I tell those people?
Oh boy, that's a good question, right? And so, this is always the cocktail, party conversation.
Yep.
So it really depends. The best evidence we have for prostate cancer screening are in young 55 to 69-year-old people who are well informed about the risks and benefits. And it seems to be that getting a PSA test, getting screened, reduces the risk of dying from prostate cancer. So that's what I would tell people. But we've had a hard time interpreting that. So does that mean every single person at any age should get it? Probably not. Screening people who are much older or who have serious other medical things going on in their life might have more risk than benefit, because you might find a prostate cancer and treat it when it was never destined to harm that individual, and then they have to deal with all of the quality of life stuff that really they didn't need to go through. So in general, it's a highly personal decision. It's something that we wish we had a snap answer for all people, but it really is something that I think is best discussed with a person and their primary care doctor. Of course, there's a benefit, right? Because we often find aggressive cancers early, and those are the ones we can treat and cure. And so there is tremendous power here. So I don't mean to be cynical about it, because screening and early detection is what is changing prostate cancer. Despite our treatments getting better and better, we are not curing people with advanced or metastatic prostate cancer. Things are getting better, but incrementally. We really bend the needle and bend the trajectory when we find an aggressive cancer early before it's spread and treat it and can cure an individual for the rest of their life.
So imagine you have a close friend or brother who is 57 years old and says, should I have that PSA? It sounds to me like you'd say, I might do it myself, but you should talk to your doctor because there are pros and cons. That's
right. That's what I would say.
Statement?
That's what I would say. I would encourage, I would go back to the evidence that having this test can, overall has the effect of reducing the risk of dying from prostate cancer. And I think that's pretty clear. And so I would encourage those people. But I've got family members who I've pushed and they say no, and I have to respect that, because as long as that's been understood, then people should make their decision.
And is it also fair to say that if you were talking to your 82-year-old great uncle, that you would probably suggest that he not continue to have screening?
I would. I absolutely would. And that, I think, is something that is really difficult to navigate. And I often see people who are older, and the question is, well, if I've been screened for years and years, and as we get older, when do you stop? Right. And that's a hard conversation, because when we suggest to stop, that doesn't mean that we're saying we don't think you have a long life expectancy or that your cancer is worth finding. So there's that stigma that, you don't think it's worth finding this. And it's a difficult conversation, and try to convey that it's really not that. Of course, we want you to live a long and full life, but there's the potential for making that life worse. And I think that is a centering point that people get. But that's still tough. There's no roadmap for that. Unfortunately, that falls in the lap of a lot of our primary care doctors, who are our partners in prostate cancer care. So,
well, I had that same difficult conversation with my mother about mammography, and advising her as the son who's a breast cancer doctor. And I can tell you that conversation was also a little difficult. So let's shift a bit and talk about not intervening. So someone is diagnosed with prostate cancer. They've been screened. They have a biopsy done. And sometimes I know, and increasingly, they're advised, maybe you don't need to do anything right now. So what's that about?
That's right. And so it all goes back to that understanding that many of the cancers we identify with screening are not aggressive. And in particular, we find these lower grade cancers when we go looking for them, when we do screening. And we have very reliable systems for identifying which ones are aggressive and which ones are not aggressive. And so the idea is that we can carefully monitor those that are non-aggressive and offer treatment in the future should something change while that window of opportunity for cure is still there. And that is a protocol that we call active surveillance. And that has also really revolutionized our approach to prostate cancer, because I think it's allowed screening to happen with a better balance of risk and benefit. So by only treating the truly aggressive ones, we are reducing the risk of over-treating the non-aggressive ones. Many people who start on active surveillance need to be treated eventually, so up to 50% will eventually need some form of treatment. But I think it has really moved the needle in terms of reducing unnecessary surgery, unnecessary radiation, and the associated effect.
Sure. And I can imagine that conversation is a difficult conversation as well. And I guess the question I have is, are more people opting for that approach than was the case years ago?
They are, yes. There's really been a real change over the past few years. And it used to be where that was a difficult conversation and it seemed heretical to say, you found prostate cancer and you're not going to treat me for this. But people have really come around to it. So the majority of people who have a low risk prostate cancer are being monitored in the United States. At Yale, it's much higher than that, near the majority. And I think people have really come around to that idea. Believe it or not, I don't think it's as hard of a conversation as it used to be. And I think hopefully our patients are understanding that this is really grounded in evidence. There have been large trials that have randomized people to have surgery, radiation, or carefully monitor their prostate cancer. And for up to 15 years of follow-up, there was no difference in survival between surgery, radiation, or careful monitoring, with about a 99% survival in all of those groups.
And I guess the one thing we have to remember is that when we're doing active surveillance or careful monitoring, that does involve monitoring. And we have to have systems and make sure that people come back and have that monitoring to keep them from getting into any kind of difficulty.
That's exactly right. And that's a challenge. We published a paper on that last year looking at the state of monitoring in the Medicare population. And there are a lot of folks who start active surveillance who do not go back for an additional test or additional testing. And so we are leading efforts and really interested in ways that we can make things better, to put systems in place that promote recall and do this more safely.
So in our last minute, if you could just comment briefly about prostate cancer in younger individuals. So in general, it's a disease of people who get older. You talked about screening in people 55 to 69, but there are occasionally younger people with prostate cancer. And how common is that? Or is it just so uncommon we shouldn't even talk about it?
Absolutely. No, it is more and more common. We are doing more screening in younger people, which I think is a good thing because we are finding aggressive cancers earlier. It's a very different approach. I think the considerations are very different for a younger person who may be considering fertility, whose urinary and sexual function, the stakes are a little bit different.
Dr. Michael Leapman is an associate professor of urology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.